Hello, dear friends. Nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we will talk about the last part 6 of Fleischner Society 2024 glossary of terms for thoracic imaging. Let's start. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society Glossary of Terms for Thoracic Imaging by Alexander A. Benkier et al. Radiology 2024, 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Let's start. Pneumatocoel pathology. A pneumatocoel is a thin-walled, gas-filled cystic structure in the lung parenchyma. Pneumatocoels can be caused by pneumonia, trauma, including barotrauma, or aspiration of hydrocarbon fluid. For example, in fire-eating, pneumatocoels can be transient and are likely caused by a combination of parenchyma necrosis and a check valve airway obstruction. At imaging, pneumatocoels appear as rounded, thin-walled cystic lesions in the lung parenchyma, sometimes with an air fluid level. Pneumatocoel pathology. Arrows indicate pneumatocoel with air fluid level in axial and coronal reconstruction CT images. Pneumomediastinum pathology. Pneumomediastinum is an abnormal collection of air or gas in the mediastinum, outside of the esophagus and tracheobronchial tree. It can be caused by a spontaneous rupture of alveoli, by trauma, or by esophageal rupture with a subsequent incursion of air along the axial interstitium into the mediastinum. It is most often associated with surgical trauma, barotrauma, or conditions related to prolonged cough, such as asthma or interstitial lung disease. At imaging, pneumomediastinum appears as one or more low attenuation areas of linear or band-like air collections outlining mediastinal structures. Pneumomediastinum pathology. Arrows indicate the outside, outlining the tracheobronchial wall, indicating pneumomediastinum. Pneumomediastinum pathology. White arrows indicate pneumomediastinum, and black arrows indicate right pneumothorax in interstitial lung disease patient. Pneumomediastinum pathology. Arrow indicates continuous diaphragm sign of pneumomediastinum. Pneumomediastinum pathology. Angel wing sign, spinacocele sign. Arrows indicate angel wing or spinacocele sign of pneumomediastinum in a neonate. Pneumonia pathology. Commonly used diagnostic term that typically designates infection of the lung parenchyma. Pneumonia can be caused by bacteria, virus, fungi, parasite, or other microorganism, and can be focal or multifocal. Pneumonia can manifest as opacity, potentially accompanied by air bronchograms, tree-in-bud opacities, or pleural effusion. Pneumonia pathology. Arrow indicates opacity with air bronchograms in left lower lobe, showing us pneumonia. Pneumonitis pathology. Pneumonitis is a diagnostic term that designates inflammation of the lung parenchyma, both infectious and non-infectious. Infectious pneumonitis is generally referred to as pneumonia. Non-infectious pneumonitis can be caused by a wide range of conditions, including aspiration, hypersensitivity, radiation, autoimmune disease, and drugs. The term pneumonia and pneumonitis are sometimes used interchangeably, but the above definitions are preferred. Pneumopericardium pathology. Pneumopericardium is the accumulation of air in the pericardial cavity. Pneumopericardium has been described in preterm neonates or in the context of mechanical ventilation in infants. In adults, it is usually due to trauma or cardiac surgery. It can be associated with other pathologic air collections such as pneumomediastinum or pneumothorax. At imaging, pneumopericardium manifests as air or gas attenuation in the structureless space separating the two layers of the pericardium. Pneumopericardium pathology. Arrows indicate pneumopericardium after cardiac surgery. Pneumothorax pathology. Pneumothorax refers to presence of air or gas in pleural space that separates the parietal and the visceral pleura. Therefore, parts of the lung can partially or completely collapse. Pneumothorax can be caused by spontaneous rupture of flaps or by mechanical trauma, including iatrogenic damage. The diagnosis of tension pneumothorax is determined by clinical and physiologic criteria that typically correlate radiographically with contralateral mediastinal shift, depression of ipsilateral hemidiaphragm, most often based on a check valve mechanism. Ultimately, definitive diagnosis of tension pneumothorax is determined by clinical and/or physiologic criteria. Pneumothorax pathology. Arrows indicate right lung pneumothorax, showing us visceral pleura of the collapsed lung. Left film is inspiration film and right film is expiration film. Pneumothorax pathology. Black arrow indicates right pneumothorax and white arrow indicates emphysema on left upper lobe. Pneumothorax pathology. Arrow indicates a spontaneous pneumothorax in an interstitial lung disease patient. Pneumothorax pathology. Arrow indicates tension pneumothorax in right lung. Pneumothorax pathology. Pneumothorax is typically identified on upright chest radiographs by the presence of a curvilinear visceral pleural line, indicating the demarcation between pleural air and aerated lung. However, on radiographs acquired in the supine position, when the separated pleural surfaces are not tangential to the X-ray beam, pneumothorax may be difficult to detect. In these cases, ancillary findings such as unusually sharp interface between lung and mediastinal or cardiac structure can be helpful. The deep circle sign refers to an abnormally deepened costophrenic angle which has row attenuation and is abnormally sharply defined. Pneumothorax pathology. Deep circle sign. Two white arrows indicate deep circus sign. One vertical arrow indicates sharp interface of diaphragm due to Mach band effect. Black arrow indicates normal side of diaphragm. Saber-sheath trachea pathology. Saber-sheath trachea refers to the abnormal shape of trachea with an increased sagittal AP and a decreased coronal left and right diameter, which resembles the sheaths of a saber. To meet the definition, the internal coronal diameter of the trachea must be less than 2/3 the sagittal diameter at the same anatomical level without any extrinsic cause of compression. Saber-sheath trachea is most commonly seen in patients with COPD and is assumed to be the result of chronic inflammation and subsequent remodeling of the tracheal wall. Saber-sheath trachea. Arrows indicate saber-sheath trachea and an emphysema patient. You subscribed and liked. Thank you very much. Be healthy, wealthy, and happy. Secondary pulmonary lobule anatomy. A secondary pulmonary lobule is the smallest structural unit of the lung parenchyma, surrounded by a connective tissue sheath. It is irregularly polyhedral or pyramidal in shape, with borders ranging from 5 to 25 mm in length. It contains 3 to 25 acini. The structures in the center of the secondary pulmonary lobule, core structures, centrally lobular structures, include bronchioles and their accompanying pulmonary arterioles and lymphatic vessels. The connective tissue envelope of secondary pulmonary lobule contains veins and lymphatic vessels. The secondary pulmonary lobule also has an internal support structure, intralobular interstitium. CT can help visualize the three basic components of secondary pulmonary lobule, namely central structures, region where acini are located, and connective tissue sheaths that forms interlobular septa. If you want to know more about the secondary pulmonary lobule, please refer to this paper, Ito Harumi et al., Diffuse Lung Disease, Pathologic Basis for HRCT Findings, Journal of Thoracic Imaging, 1993, Volume 8. Secondary pulmonary lobule anatomy septum. Arrows indicate two secondary pulmonary lobules in right middle lobe and right lower lobe. Secondary pulmonary lobule anatomy septum. Arrows indicate secondary pulmonary lobule in an interstitial pulmonary edema patient. Secondary pulmonary lobule. Arrows indicate secondary pulmonary lobule. Right side film shows thickened secondary pulmonary lobular septum in interstitial pulmonary edema patient. Secondary pulmonary lobule anatomy. Arrow indicates secondary pulmonary lobule in a lymphatic carcinomatosis patient. Segment anatomy. Segment is a structural unit of a lobe ventilated by a segmental bronchus, perfused by a segmental pulmonary artery, and drained by an intersegmental pulmonary vein. The right lung has 10 segments, with 3 in upper lobe, 2 in middle lobe, and 5 in the lower lobe. The left lung has either 8 or 10 segments, depending on whether apical posterior upper lobe segment and anteromedial segment in left lower lobe are considered to represent 1 or 2 segments. At imaging, individual segments are identified inferentially based on the position of supplying segmental bronchus and artery. Occasionally, segments can be separated by accessory fissures. Septum, pleura, septa, anatomy. Septum is a sheath-like connective tissue structure surrounding secondary pulmonary lobule. Because they separate lobules, they are also referred to as interlobular septa. They contain veins and lymphatic vessels. Being oriented perpendicularly to the pleura, isolated septal lines can be occasionally seen on CT exam in otherwise healthy patients, and the lung apexes and bases as thin linear structures separating secondary pulmonary lobule. They are more conspicuous when thickened in interstitial edema. The adjectival form septal is commonly used with the following terms: line anatomy, linear structure representing an interlobular septum. Septum, pleura, septa anatomy. Arrows indicate septum in right lower lobe. Septum, pleura, septa anatomy, thickening, pathology, seen on chest radiographs and CT exam as thin linear structures at right angles to and in contact with lateral pleural surfaces, formerly referred to as curly lines on radiographs, an obsolete and non-recommended term. They reflect the accumulation of fluid or tumor in the interstitium. For example, in pulmonary edema, lymphangitic carcinomatosis, and/or mechanical lymphatic obstruction. On CT exam, septal thickening can be smooth or nodular, which may have to differentiate edema from lymphatic infiltration or obstruction. Septum, pleura, septa anatomy, septal thickening. Arrows indicate septal thickening on frontal radiograph, formerly called as curly lines. Septum, pleura, septa anatomy, septal thickening. Arrows indicate septal thickening in coronal CAT scan in lymphangitic carcinomatosis patient. Signet ring sign pathology. Signet ring sign refers to ring-shaped structure representing a dilated bronchus, imaged perpendicularly, accompanied by a smaller, adjacent rounded and dense structure representing accompanying pulmonary artery. The combination of both resembles a signet or pearl ring. It is considered typical of bronchiectasis, but can also be seen in diseases with abnormally decreased pulmonary arterial flow, for example, chronic thromboembolic disease or proximal interruption of the pulmonary artery. Signet ring sign pathology. Arrow indicates a signet ring sign of bronchiectasis in left lower lobe. Silhouette sign pathology. The silhouette sign refers to obscuration of a normal silhouette or interface and results from the juxtaposition of structures with a similar radiographic attenuation that obliterate normal anatomic borders or interfaces. However, it is not always indicative of pulmonary disease. For example, obscuration of the heart border can sometimes be caused by anatomic variants such as pectus excavatum. Silhouette sign pathology. Arrows indicate right heart border, preserved right heart border. Left chest radiograph shows silhouette sign positive of right middle lobe pneumonia. Radiograph on right side shows silhouette sign negative of right lower lobe pneumonia. Silhouette sign pathology. Arrows indicate preserved normal left heart border. Chest radiograph on left side shows silhouette sign positive left upper lobe pneumonia, and chest radiograph on right side shows silhouette sign negative left lower lobe pneumonia. Small airway disease pathology. This umbrella term summarizes diseases of peripheral airways. The definition of term vary. Some radiologists consider small airways as those with an internal diameter of less than 2 mm and wall thickness of less than 0.5 mm. Others place demarcation between central and peripheral airways at the level of a bronchiole. Although two definitions are not consistent, the first one appears more practical and is more commonly used in the literature. On CT exam, these diseases can manifest as peribronchial and or bronchial abnormalities, including 3 in-bird opacities, centrilobular micronodules, air trapping, bronchial ectasia, oligemia, or a combination of these findings. Speculation, pathology, descriptor. Speculation is a descriptive term referring to multiple fine linear strands extending from a structure, for example, nodule or its component, into the surrounding lung parenchyma in a stellate manner. Pathologically, speculations are often associated with a desmoplastic process, for example, an invasive malignancy within nodule resulting in fibrotic strands radiating into the surrounding lung. Speculations can also be associated with direct infiltration into adjacent bronchial or vascular structures or focal lymphangitic extension. Speculation in a nodule increases the likelihood of cancer, although it is not specific. Speculation, pathology, descriptor. Arrows indicate speculations of right upper lobe adenocarcinoma. Speculation, pathology, descriptor. Arrows indicate speculation of right upper lobe non-small cell lung cancer. Tracheomalacia, tracheobronchomalacia, pathology. Terms tracheomalacia and tracheobronchomalacia are used when there is excessive inward movement of the trachea and or main bronchi during expiration due to pathologic weakness of cartilaginous airway wall. The closely related term excessive dynamic airway collapse is used when tracheobronchial collapse is due to excessive invagination of posterior muscular trachea or main bronchial walls during expiration. Both entities can be diagnosed with dynamic expiratory CT. However, it is important to be aware that in healthy individuals, the trachea may collapse by 70% or more during a forced expiration. Tracheobronchomalacia pathology. Arrow indicates tracheomalacia. You quit smoking? Wonderful. Your great job of the year. Congratulations. Now you finished part 6. Wonderful job. Great is the job. Congratulations. See you soon again on total of glossary of the thoracic imaging.